Hi, everybody. I'm Dr. Cuartas from actually from Crystal Run Healthcare. I'm a spine surgeon. I do 90%, 95% only spine surgery. So just first off, I'll go through just a couple of slides to talk about different conditions that are common that we treat. And then I'll open up for questions. I think that sometimes works well. So just in general, there's a lot of back pain, strict back pain, and in general, it's quite a big problem in the U.S. and in other countries as well. And we don't necessarily do surgery on just back pain, but rather we tend to not do surgery for just back pain by itself. And then I'll explain what I mean by that. It's kind of, okay.
Try again.
Yeah. There you go. Because that's what we call back pain. We call it nonspecific back pain. And so it can have a lot of different causes. As we see here, we have, it can be just basically because you lifted something or something like that, a muscle type of pain, a little bit of a joint pain. But then there are these other conditions that can really cause major issues, and it's hard to distinguish by whatever symptoms you're feeling, if it's a bad problem or if it's a mild problem. So, for example, a disc that's ruptured will give you some back pain. This condition, which is basically instability due to arthritis in the back, it's called degenerative spondylolisthesis, but basically just means that there's arthritis and the joint is loose. Stenosis means narrowing of the spinal canal. And then we have other things like scoliosis and things like infection, cancers, fractures. They can cause back pain. So these things on the right are really the sort of conditions that I end up sometimes treating with surgical and non-surgical means anyway. And so we kind of clinically try to distinguish, okay, what are some ways to exclude and sort of clinically decide that some back problems are probably not going to end up requiring surgery, not too serious. So if it's only been present for a couple of weeks, it still has a chance of getting better if there wasn't any trauma, for example. And this is a key thing, is if there's no pain or weird symptoms like numbness going down the legs, because those we call radiating pains. Though obviously no fevers, no night pain. Night pain is when there's pain at night that can wake you up. That can be a problem, mainly for infection and cancer, actually bad things. If there's no past medical history of anything suspicious, and also if the patient's like within a certain age range where we don't see a lot of trouble, if everything is otherwise fine. For example, if you're younger than 20 years old and you're complaining of back pain a lot, that's not entirely normal. And at the same time, I think that probably what this means is by the time you get to 60 or something like that, if you have a lot of back pain, by then you're kind of probably aware of what your back can do for you. And if you're having a lot of back pain, that means something's going on. So anyway, that's why those age ranges are there. So basically, if it's really, and also if it's not getting better, sometimes we'll get an imaging like X-rays, MRIs, and things like that. However, if If it is getting better, then we just do simple things like anti-inflammatories, resting, avoid activity modification, which is no bending, lifting, and twisting. Some medications are helpful. Obviously, we've all realized that that it's important to try to stay away from narcotics to treat these simple episodes of back pain. Physical therapy can be helpful, massage therapy, chiropractics, things of that nature. Local treatments like heating pad, things like that also can be helpful. So, but what if they do have one of these things that, maybe it's going down a leg and the pain is excruciating, then we would just skip ahead and do some imaging and try to figure out really what's going on with this patient. So then, we're just going to talk about 3 of these conditions that sometimes can be a little bit more serious and more troublesome. One is a disc herniation or disc disruption. And just to review a couple of things, a healthy disc is a beautiful thing. It can hold up to 300 PSI, which is a lot more than a car tire can hold. So basically, it's a very, very strong structure when you're a healthy, young person, But then over time, the discs can get damaged. And when they get damaged with gravity, they get pushed out backwards and forwards. And that's what we call a disc herniation or a disc bulge, when this structure, which is normally tightly packed and has actually positive pressure, now it's sort of in a sense, it's kind of becomes incompetent. And then with gravity, it just kind of starts coming out. Now, sometimes that can cause a problem. For example, in this drawing, we see this is a cross section, and we see this is the disc, and this is the spine, and we can see nerves coming through in this direction, and we can see the disc, in this case, has ruptured and it's bothering this nerve or compressing it. So disc herniations can have back pain, leg pain, weakness, and different sensory problems. And this is sometimes if the patient is not getting better. We do surgery where we remove a little section and we remove the piece of disc so the nerve isn't getting pinched. Now, most of the time, these get better on their own. It is very, very painful. Typically, it's a person in their 20s, 30s, or 40s. Although I've seen disc herniations that cause problems in older patients as well. But typically the discs get a little tougher and less prone to getting ruptured like this after you're maybe like in your 50s or 60s. But it can happen. This is just a picture showing how we remove the piece of disc. And these surgeries are typically small. We do small scars. And so this brings to us like a big point, which is everybody wants to know, do surgeries work do spine surgeries work? Because everybody's heard a story or two of people saying, well, it doesn't work. It's just going to make you worse. You should never have a back surgery. So, this is a large study that was started in the year 2000. It was funded by the NIH. And at the time, it was the largest orthopedic study ever funded by the NIH because it was a very important question for the government to answer. Okay, we're spending a lot of money on all these spinal surgeries. Do they really work? So all the spine surgeons decided, to get involved in this and try to see if they could get to an answer. So they looked at 3 conditions: disc herniations, stenosis, and degenerative spondylolisthesis. And these are some of the places that were involved, which, just to go quickly through some of these are major centers with major, top-notch surgeons like UCSF, Rush, Rothman Institute in Philadelphia, Hospital for Special Surgery, et cetera. So they were very, very good surgeons, and they looked at these three conditions. Then they finally came out with the data, and it came out very in a very confusing way. So they were looking at these three conditions, and they were looking at what surgeries can be done for them, and how patients do over time. So, for example, they looked at these three indices, which is bodily pain, physical function, and this is a disability index. So when they looked at bodily pain, actually a higher score is better. So it's flipped. So these patients were starting out here, and they were like in very poor shape, because this line up here is where patients normally are on average. So this is patients with disc herniation. They're like down here, they're doing terrible because they're in so much pain, they can't do a lot of things. And this is, we have surgery is the dots. And so you can see that people after surgery did better than patients that didn't choose to have surgery. And that was up to 2 years. So, I mean, if you look at this, you might say, well, everybody should have surgery for disc herniations because you do better if you have surgery. Well, but in real life, patients choose what they want. A lot of patients decide that they want to live with the pain rather than have surgery. Oh, I have to admit that person now. So in real life, people have a choice. And so this represents that a little bit, that some of these patients chose to not have surgery, for example. They looked at physical function, and again, patients did better with surgery than without surgery. And then in terms of disability, people did better. Now, if it's important to see here that even at 2 years, patients that had this problem and were doing very well after surgery, they're not doing as well as patients that did not have this problem. You see, they're still below the normal, or what's called the norm. So these are significant conditions that can impact patients' quality of life, pain, and function, even in the best of situations. That may be partly why it's hard for patients and sometimes family members to really appreciate whether a person is doing better after surgery, because they're still going to be complaining about some issues that don't appear totally normal. So this guy here is doing very well. You know, he's 2 years out and he's much, much better than he was. But if you compare him to somebody who never had this problem, maybe this guy's complaining a little bit more than a normal person. So that makes it harder to really know as a layperson, do these surgeries work? But so, for example, for disc herniation in properly selected patients, and the surgery is properly done and there's no complications and so on, surgery does work to help fix the problem. So anyway, so let's move on. So this is kind of a summary. When patients are allowed to pick or select their treatment after 6 weeks of conservative care, those that chose surgery did better at 2 years. And this was about a 10-point improvement, 12 points in physical function, et cetera. And let's now look at one of the other conditions. And similarly, I'll show you what this means. This is when you have instability. So you see this bone, the number 4 bone, L4, has slipped forward on the 5 bone. So the problem with this is, which I probably should have mentioned at the beginning of the talk, the spine does 2 main things. It's a scaffold to hold you up and to serve as the base for your body and your motion. But it's also a pipe or a conduit for your nerves to your legs. So you can see here the nerves are coming down. So when you have an area that gets shifted forward, it can get really pinchy, really narrow right here. and that's stenosis. So this is kind of what the surgeries for this look like. We try to remove the pressure. And then we fix it with screws and rods. So that's when you hear about screws and fusions. And because we want to stiffen it up so that there's no more abnormal motion at that level. And that's sort of the standard treatment. So again, if we look at these strange little plots, we see here these black dots is patients with surgery, and the triangles are patients without surgery. So you can see that the circles are doing a lot better than the triangles. And you might want to ask, what are these lines in the middle? So these lines in the middle represents what happens when you do a data analysis, with what's called an intention to treat analysis, which is the most powerful way to analyze data for statistical purposes, which means that you say, okay, this person, we're gonna roll the dice and we're gonna say, you're gonna have surgery, and we're gonna roll the dice again, and then you're not going to have surgery, and we're gonna, and so on. So it's a randomized way of telling people what treatment they're gonna have. And that's a good way to know statistically if something is better than something else, like for example, for drugs, and that's why we use placebos. But when you're treating patients for surgery, it's basically not possible for many reasons. One is, patients have the right to choose. So a lot of patients, actually what happened was that they were assigned to surgery and they said, no, you know what? I don't want surgery. So they didn't have surgery. And a lot of patients were assigned to not have surgery, and then they chose surgery. So that's called crossover. And so it turns out that about 50% of people didn't like what they were assigned to, and then they switched. So you can imagine if you switch 50%, 50-50, then basically the data is completely useless. So, but then they said, hey, you know what, how about you let us look at the data and separate them. If you really had surgery, well, we'll see what happened. And if you didn't have surgery, we'll see what happened. So that's called the as treated analysis. So when you do the as treated analysis, you see that surgery does help these patients. And for example, for this condition, it's about, 18 points for pain and 16 points for the disability index of improvement. And it turns out that you can compare different surgeries and in terms of how much pain relief you get. And the interesting thing is that that's about as much relief and functional improvement as you get from a hip replacement, which is really probably arguably one of the best surgeries that we have in orthopedic surgery, because you're not walking and then you're walking and it doesn't hurt. And it's a quick recovery. So this surgery for degenerative spondylolisthesis is very, very satisfying to patients when they are selected properly. So it works very, very well, and patients are very happy. Those are probably some of my happiest patients, the ones that have that type of surgery for spondylolisthesis, because it's a single level surgery and there's great improvements. Now, spinal stenosis is a little tougher because that just means narrowing. But in reality, when they looked at this situation, they looked at patients that had many levels of stenosis. So really an older group of patients that were basically their spine was getting a little bit narrower. And a lot of patients ask me, so what is causing the stenosis? And I sometimes use the word rust because it's basically the whole process of arthritis in all its manifestations, which means you lose height. So if you lose height, you know how you get shorter as you get older, because you lose height. So that causes a lot of crowding because now there's less height to put all that stuff. So you go from this on the left, where things are nicely stretched out, and then you go to this, and you can see now this thing is bulging in, this black thing is bulging out, this is bulging out, this is bulging out. And also the other thing that happens, you know how sometimes people's joints on their fingers get bigger? Some of these joints actually get bigger, so they encroach and they make it narrower. So this patient has stenosis from here to here. So that's important to know, because so if you have to have a surgery on 1, 2, 3, 4 levels in your spine, it's going to be a little bit harder to recover than if you had it on one single level. So that's something important. This is a surgery. We basically remove the roof of the spinal canal and make it more wide like this. And then, you know, it's important to know that since these are older patients, have other problems, and also we're doing bigger surgery, sometimes more levels, the recovery is not as satisfying to the patient. So the improvement is not as much as it is for the other single level problem. So the improvement is like maybe 13 points in terms of, 11 points for pain, 13 for pain and 11 for function. So the improvement for just across the board stenosis, there is improvement, but it's not as remarkable as for spondylolisthesis, which is this condition. So basically for these three conditions, they showed in this study that came out in 2000 that surgery works, and it does last. Nothing lasts forever, unfortunately, but it does last. And this is, you know, a part where I compare it to hip replacements and knee replacements, which are very common orthopedic surgeries. And so hip arthroplasty, if you look at this data, you see the amount of improvement is, what do I have here? So like from about 30 to 60 is 33 points and 24 points for a knee replacement in pain, and function is 30 and 25, which is, you know, for degenerative spondylolisthesis, like I said, this is the best surgical result that we usually get in spine surgery of the lower back. You have about 30 points of improvement in pain and 30 points in physical function, which is the same as a total hip replacement. So in conclusion, it's almost as good as total joint replacement. It's probably a little bit harder for patients and their family members to see the difference. So it's important to really understand what the goals of the surgery are in a particular case. So so those are three conditions, and I didn't really talk about the neck at all, but the neck is another similar, there's another similar set of circumstances, and there's some differences as well.